Hello everyone, it's Schematic Math, and today we're going to talk about initial ventilator management of acute respiratory distress syndrome. Everything starts with intubation, and we need to set initial ventilator settings. The two important components of the ventilator is oxygenation and ventilation. Oxygenation is done with the help of the FiO2, or fraction of inspired oxygen, which should be 100%, and PEEP, or positive end expiratory pressure, which should be 5 cm per water. And ventilation is determined by VT, or tidal volume, which should be 6 milliliters per kilogram ideal body weight, and respiratory rate, which should be 14 to 18 per minute. And of course, sometimes we need to do some adjustments. We can adjust the oxygenation and we can adjust the ventilation, the parameters that we already talked about. When we need to adjust the oxygenation, we can either change FiO2 or PEEP. When a patient has hyperoxia, when PaO2, which is partial pressure of oxygen, is more than 90 mm per mercury, decrease the FiO2. If the patient has hypoxia, PaO2 is less than 60 mm per mercury, increase PEEP. This will recruit collapsed alveoli and will decrease intrapulmonary shunt. If we need to adjust the ventilation, we can change respiratory rate or tidal volume. If patient has acidosis, pH is less than 7.25 and PaCO2 is very high, we will increase respiratory rate, and at last resort we will increase tidal volume. One more time, firstly we are increasing respiratory rate. And when patient has alkalosis, pH is 7.45 and more, and PaCO2 is low, we will decrease tidal volume, we can decrease the respiratory rate, and at last resort, we will increase the sedation. And lastly, let's talk about a very important point. When managing mechanical ventilation, one of the key principles is lung protective ventilation, which helps prevent alveolar overdistension and lung injury. How do we achieve this? A crucial step is evaluating lung compliance by measuring plateau pressure, P-plat. This is done using an inspiratory hold maneuver, where the ventilator is paused briefly after delivering a tidal volume. The pressure recorded at this moment reflects lung compliance and alveolar distension. The target is to keep P-plat 30 and less centimeters per water, as higher pressure increases the risk of ventilator-induced lung injury. If P-plat exceeds 30 centimeters per water, we need to make changes. We can decrease tidal volume or VT to reduce lung stretch, and adjust PEEP or positive end expiratory pressure to optimize oxygenation while minimizing overdistension. Optimal PEEP settings may improve mortality rates in patients with severe